versus the NSQIP were a historical cohort. It was chart review. So when we talk about preoperative cardiac testing, what needs to be done? So no preoperative cardiac testing should be done if it will not change the perioperative management for a patient. Now, that's where it's a little tricky if we're going to say that, but that is explicitly stated in the most recent 2014 AHA guidelines. For us, as the anesthesiologist, more often than not, it's going to change how we manage the patient intraoperatively. So for us, it may be important to obtain certain preoperative cardiac testing for patient populations. So exercise tolerance is going to be a very important indicator of a patient's cardiac risk. The better functional status a patient has, the lower risk it's going to be for them. When we talk about functional status, it is a reliable predictor of cardiac events. In the AHA guidelines, they say in highly functional, asymptomatic patients, it is often appropriate to proceed with planned surgery without further cardiovascular testing. So functional status can be estimated by patients' activities of daily living. It's where we qualify the METs. So the one metabolic equivalent is the equivalent of the resting basal oxygen consumption for a 40-year-old 70-kilo male. If we're going to say excellent functional capacity, it's a METs of greater than 10 versus poor is less than 4. And that's where we need to do a little bit more investigation into the patient's history and functional status. So examples of METs is going to be, if greater than 6, you're going to be healthy, running around, exercising, swimming. If we're talking moderate intensity, it's going to be your household chores, gardening, walking a pet, things like that. So the old guidelines were from 2007, and now we have the newer guidelines from 2014. And these are the most recent guidelines, and we'll go through them step by step. So step 1, a patient scheduled for surgery with a known risk factor for coronary artery disease. Is it an emergency or not? If it is an emergency, you do a risk stratification and proceed straight to surgery. And you monitor the patient however you feel is appropriate for that specific patient. If it is not an emergency, then you go on to step 2. If the patient has any ACS symptoms, you evaluate and treat based on guideline-directed medical therapy. If yes, you can refer them to cardiology for further evaluation and any investigation that they may need. If no, then you estimate the perioperative risk for a major adverse cardiac event based on the patient's medical history. If the patient has stable risk factors, it has an appropriate METs, then they're okay for surgery. This is where your risk indices are going to come into play. So if a patient has low risk, then no further testing is needed. You can go straight to surgery. If the patient has an elevated risk for a major adverse cardiac event, that's when you have to do further investigation. You have to determine the patient's functional capacity. Now, that can be objectively based on the patient's activity level, if they are able to ambulate around the house without any difficulty, any dyspnea on exertion, chest pain, things like that. If, however, you cannot determine a patient's functional capacity, that's where further investigation may be needed. You may have to get additional cardiac testing for that. So if the patient has poor functional capacity or unknown functional capacity, that's when we need to determine what investigation needs to be done. Do they need stress testing, whether it's exercise stress testing or pharmacological stress testing? And if they have an abnormal result, do they need to go for coronary angiography? Do they need revascularization? And that's where it's going to be where we have to communicate closely with both the surgical team as well as the cardiologist to determine what the best course of action is for the patient. Bottom line, if the testing is not going to impact your management of the patient or your care of the patient, then you can go straight to surgery. If, however, it is going to affect your management of the patient. Say the patient has a very poor cardiac history, is not a candidate for surgery, then they have to consider alternative treatment options, possibly palliative options, although I think that's something that we're not doing as frequently. So, supplemental preoperative evaluation. Should we routinely obtain EKGs? The answer to that question is no. And yet we all see it. You'll see a healthy 24-year-old come in for a knee who has an EKG, and it doesn't make any sense. Routine EKGs in asymptomatic patients is not indicated. So who gets a 12-lead EKG? Patients with known coronary artery disease, history of arrhythmias, significant peripheral artery disease, structural heart disease, with the exception of low-risk surgery. Cataracts don't necessarily mandate EKG for patients. Now, you can always consider an EKG in those without any coronary disease, except in low-risk surgery. Now, this is where your clinical judgment comes into play. If a patient has hypertensive and multiple diuretics, then maybe they do need an EKG to evaluate for any electrolyte abnormalities that may be causing any arrhythmias for them. When should an EKG be done? Now, there is no specific guideline that says an EKG needs to be done 6 weeks before surgery. I think the consensus amongst cardiologists as well as anesthesiologists is that it should be done within 1 to 3 months for stable patients. Should we evaluate left ventricular function for patients? Routine evaluation with echocardiography or any stress testing is not indicated. However, patients with exertional dyspnea, heart failure patients, it is indicated. So for a heart failure patient, when would we obtain an echo to evaluate their function before proceeding to surgery? If a patient is clinically stable and has had an evaluation within 1 year, then there's no indication for it. However, if a patient has worsening exertional dyspnea, change in their functional status or clinical status, and a patient has no assessment within the past year, that's when you would further evaluate them. And this is where it comes in, where you get these nursing home patients who are demented with a hip fracture come in with a vague history of heart failure, and they're coming in for like a Hemi. Do we further evaluate them? And oftentimes the medical team will say they're cleared for surgery, but you have no assessment of their functional status at all. You don't know you know nothing about their heart. And in those situations, it may be appropriate to do further evaluation with an echocardiogram. So should we do any exercise stress testing? Routine screening, again, not indicated. This is going to be a common theme. Exercise stress testing should be done in patients who have elevated risk or poor or unknown functional capacity, only if it will change management. If you have a patient who is going to refuse a stent, no matter what you say, it's not going to change your management of that patient. It may from an anesthetic standpoint, but it's not going to change the management for the patient from an outpatient standpoint. Patients with elevated risk, with high functional capacity or even moderate functional capacity, do not need an exercise stress test. It would be based on your clinical judgment whether you think it's appropriate for that patient depending on what kind of surgery they're coming in for. Pharmacological stress testing. When is this appropriate? Patients who cannot do an exercise stress test. Their functional capacity limits them from doing an exercise stress test. Again, routine screening is not going to be appropriate for these patients. So, radionuclide myocardial perfusion imaging. It's not something that I think any of us will ever order, but this is something that can be discussed with a cardiologist. It's going to be there to evaluate perfusion defects, and it's going to show if a patient has any ischemia. An abnormal study has a very high sensitivity for detecting any adverse perioperative cardiac events, whereas a negative study has a high negative predictive value for cardiac events. Now, the key is that if you have a reversible myocardial perfusion defect. If you have a reversible myocardial perfusion defect, it is highly predictive of perioperative cardiac events. Which brings us to, should we do preoperative coronary angiography? Routine, again, is not indicated. Should these patients be revascularized to reduce any perioperative cardiac events? The answer is no. They should not be revascularized unless they absolutely need it. So revascularization before non-cardiac surgery is only recommended in certain events. So if a patient has unprotected left main disease, significant coronary artery disease, where it is urgent or emergent for them to have revascularization. Patients with unstable coronary artery disease or candidates for emergent or urgent revascularization are the ones who should get revascularized. But standard revascularization for patients with coronary artery disease to prevent perioperative cardiac events is not indicated. So, which brings us to the CARB trial. This was a study, it was a randomized controlled study. It showed no difference in perioperative or long-term cardiac outcomes with or without preoperative CABG or PCI in patients with coronary artery disease, with the exception of left main disease, poor ventricular function, and severe aortic stenosis. Now, patients who actually underwent revascularization actually had delays in surgery, and that's where the time-sensitive surgeries come into play. Will revascularization delay any oncological surgeries that a patient needs to have done and delay any treatment options for them? So just as a review, if the patient has PCI and surgical timing, so if it's a balloon angioplasty, you have to wait 14 days. Bare metal stent, 30, drug-eluting is 365. Now, drug-eluting stent is a little bit more tricky. It can be considered to do surgery within 180 days if further delay of surgery is going to result in poor outcome, and the risk of delaying surgery is actually greater than the risk of any stent thrombosis or ischemia. Elective non-cardiac surgery should not be performed within 14 days of balloon angioplasty in a patient where they will need to hold their aspirin preoperatively. So, perioperative beta blocker recommendations. Chronic beta blockade, continue the patient's beta blocker. However, use your clinical judgment. Now, I know it's a CMS guideline or a CMS mandate to start continuing a patient's beta blocker, and you get judged on it if you don't do it. However, if it is not indicated for patients, if they're hypotensive or they have any other indication to hold their beta blocker, then it's appropriate to hold it. Should we start a beta blocker preoperatively for these patients? In certain populations, it is reasonable. Intermediate or high-risk patients can have a beta blocker started. These are patients who have more than 3 RCRI risk factors. However, do not start it on the date of surgery, and it needs to be started with enough time to evaluate the effect on the patient, if it's an appropriate regimen for the patient. The POISE study, although flawed in its own ways, showed that patients who started a preoperative beta blocker had higher risk of stroke and death. Statins. Statins should be continued preoperatively. In fact, for vascular surgery in particular, it's appropriate to start a statin preoperatively. It can be considered in patients who have at least one clinical risk factor who are undergoing intermediate risk procedures. So, which brings us back to antiplatelets. If you have a history of a bare metal stent or a drug-eluting stent within 4 to 6 weeks, dual antiplatelet therapy should be continued, with the exception where bleeding outweighs the risk of stent thrombosis. If you're going to discontinue Plavix, then aspirin should be continued for these patients, and Plavix should be resumed as soon as possible. Now, this is something that needs to be discussed in conjunction with the cardiologist as well as the surgical team. Oftentimes, we hold aspirin for these patients who have a history of stents, and it may or may not be appropriate depending on the patient. If we continue aspirin, if a patient has a previous stent, then aspirin should be continued when there is a risk of potential stent thrombosis or an increase increased risk for a cardiac event. You can discontinue aspirin when there's no history of stenting and if it's just purely prophylactic. There's no need to continue aspirin, unless of course the patient is high risk for ischemia. So this is just a slide to show how to approach patients with coronary stenting. And I think we just powered through all of that. Questions? No?
Should we?
Sure, what?
I think like you brought up several points. Number one, the preoperative EKG. There's so many times in like, you know, Nicole will hand you a chart to review and they'll say review this EKG. Like it's just, it's totally impossible. I mean, the only thing you can tell from that is whether they're having an active MI or not.
Exactly.
So I think it's useless. I wish we would completely eliminate that. The other thing is, we have to stop, we have to realize that the cardiologists here, I hope they're all standing out here, have no idea what we do. And we need to not rely on cardiology to clear the patient at all. Their job is to optimize and risk stratify, and that's it. And they get themselves wrapped up in these preoperative clearance all the time. And they're stuck between a rock and a hard place because, you know, they feel like they have to clear these patients when, you know, these patients are super high risk. So they're going to start only risk stratifying patients and optimizing. So we can't count on them to say, oh, the patient's cleared for surgery. We clear the patient ultimately because we take them. So I think that's you know, they don't understand what we do in the operating room. So their judgment on things is impaired. We've run into a number of problems where you'll have a stress test that's abnormal, and you know they say, well, maybe the patient needs and further ischemia workup after surgery or something like that. You know, they have no clue. So I think that's just a culture shift that we have to do.
Well, in regards to EKGs, we have tried very hard to educate them about not getting EKGs unnecessarily.
Well, it's on all the labs. It's like CBC, BNP, PTINR for everything.
As well.
Yeah.
And the same thing, the guidelines are out there.
Yeah.
We've met with all the offices,
Yeah.
but they choose to do what they want to do.
Right.
They're still going to do it. But on Medicare patients, they don't pay for EKGs unless you meet the 5 criteria that you mentioned.
Yeah.
So the patients actually have to pay out of pocket.
That's unfortunate.
So, and they fight about it, but it happens every day, but there's nothing we can do. So it's a battle I've had for 10
Yeah.
years, and it's not very successful.
Well, I think, but when they have EKG and they're giving it to you,
You have to look at it.
yeah, I mean, I guess you have to look at it, but you can't make any judgment on
No.
what it is. So like saying it's okay for surgery is, I just say, no MI, but I don't.
Well, if it's an AFib and you don't have anything previous, then you gotta find out if it's
Or a
been
left,
an AFib.
a new left one.
A new left bundle, but, and the guidelines are out there, and they're only should be showing you those. Those that go through PST should only be showing you the ones that fit within the guidelines. They don't show you.
You mentioned low-risk surgeries, and you included plastics without.
We're talking about like breaded, but not like the big fluid shift plastics cases.
Well, let's say
They're
it's
doing.
not a big fluid shift plastic. Yet, I didn't see, maybe I missed it, the duration of surgery. I thought it's an independent risk factor for perioperative cardiac event is the surgery or anesthetic rather for over 3 to 4 hours.
It is.
And,
So-
our plastic surgeons, I don't know any case that they do less than that. So basically that puts them with a low fluid shift, the surgery basically are in the higher risk for
It is.
perioperative
It would be in the higher risk if it's going to be an extended surgery. I'm talking about, when we talk about plastic surgery, I'm talking about outpatient plastic surgery at a surgical center that's like quick and easy. Not the kind of stuff that we.
Should we treat these patients who you anticipate the surgery with the risk factors? The risk factors for cardiac event, should we treat them even though they're coming for the lower fluid shift surgery type of situation? Yet we know the duration is going to be over 3, 4, 5 hours.
Depends on their risk factors. If they have significant risk factors, then yes, I think we do need to treat them as intermediate or higher risk patients coming in for surgery. If it's like a otherwise healthy patient who, like, is a healthy 40-year-old with breast cancer who's coming in for like mastectomy, resection, and like breast implants, and that's a different story.
I understand. So the duration of surgery is an independent factor. So for cataracts, probably not even going to look at the EKG.
Yeah.
Don't.
We
But
we
for
order them.
right. But for mastectomies with reconstruction, even though with the patient with the risk factors, I think we have to consider workup on the cardiac side, even though it's going to be a low fluid surgery.
I agree. I think it's fair.
But something like years ago, I had a patient that had not a huge, but a small reversible defect in a stress test and had colon cancer. And, the problem is if they do these stents, especially the drug-eluting or the ones that need anticoagulation,
For a year.
then you can't operate on them. You put in the stent beforehand, you have to stop the Plavix.
But you can do a non-drug-eluting stent and take them off anticoagulants in a month.
Well, yeah.
That's what people do now. If you have an urgent surgery, I mean, that's what the whole risk reduction clinic's about, or those are the people we're trying. I just saw one last week who needs a esophagectomy, and he was short of breath with his groceries, so we sent him to be evaluated plus a stress test, getting cath, but they'll put a non-drug-eluting stent. So there are options out there that weren't previously in the past.
And then there are situations where I had a patient come in for oral tongue cancer surgery who had a reversible defect on a stress test the day before, and the cardiologist said, there's really nothing to do. He's as good as he's gonna get. And so we did the case. I mean, the guy did fine, but it's like
You just say he's high risk.
he's high risk, and the patient obviously had no idea until I told him. But that's what happens.
But there is a case to be made for patients who are optimally medically managed that
Yeah.
don't require intervention or can't
Exactly.
require intervention. So some people have small vessel disease and they can't, stents don't work for them. So it's all about weighing this, right? So
Yeah.
making the patient informed and shared decision making with the family and the doctors who are taking care of the patient to make sure that everybody has a good sense of what where the potential outcomes are.
Yeah.
There's no right or wrong.
It's something that I had somebody say to me once, is when you look at a patient, always think, is this as good as this patient's gonna get before they do surgery? Can you get them any better? And if you can't, then you weigh the risks and the benefits and you just move forward.
And our guidelines are EKGs are good for 6 months, and there are only 5 indications. But that doesn't mean you're not seeing them on people in labs, unnecessary labs every day.
Yeah.
But it's a battle we try and constantly try.
The diabetic has to be on insulin to get EKG, because they used to talk about silent ischemia and all the diabetics.
Yeah.
But PO meds is not a risk factor.
PO meds is not considered a high risk factor.
I think that's the only probably scenario where EKG, random EKG may show you something, and those guys, that's a silent lie. Insulin dependent diabetic.
I think the people who've been a diabetic for 10 years or greater, they still get EKGs for most places. And we don't use when you see on the risk stratification from the clinic, we use the QXMD
Okay.
calculator. And the reason we use that one over the NSQIP calculator is NSQIP, you can't complete the survey if you don't have, it's really an inpatient survey.
Yeah.
It's a high-risk inpatient survey. It considers ascites and all these other
Yeah.
factors that we don't have on an ambulatory basis. So we use QXMD for cardiac and pulmonary. When you see those calculation numbers on the combined hospitalist anesthesia note from the clinic. So that's what.
That's fair. The NSQIP is very, very thorough. I mean, it goes into things that I don't think we always look at, and it doesn't affect it. It's not appropriate for all patients.
But, and it's hard to calculate if you don't have all those things.
Exactly.
And we don't.
I mean,
I see a lot of these unnecessary tests down in the, lithotripsy. When, you know, the nurses ask for EKGs for any people with hypertension or diabetes or obesity.
Over 50.
And then the EKG says abnormal EKG for whatever, like, you know, the two-way changes
Yeah.
or, you know, ICDs, whatever, and then somebody, you know, write EKG, on the EKG say, need a cardiac clearance just because it says abnormal EKG. And then they have to go through all the cardiac workups, they get stress tests and all that stuff, and it always comes out to be negative.
Yeah.
I mean, there's so
It's
much.
a low-risk
unnecessary-
procedure, too.
For low-risk procedure, they
Yeah.
think, you know, we are having some kind of, bowel surgeries or open heart surgeries. I mean, like, they do all kind of workup, because these cardiologists, when we ask for cardiac clearance, they have no idea what the lithotripsy is. So they do all these workups, they came out negative, with spending all that money and tests. I mean, there's so much of that stuff.
Yeah, I did 2 solid hour meetings with Cornhole or whatever his name was. During the time that Patty Murphy was here.
Yeah.
It would, I could have talked to that desk, it would have been more value. It went from him to the regional, you know, their whole group,
Yeah.
and Cornhole won. So we can't change it.
But the problem I have now is these old veteran nurses are gone. Now they have all these new nurses that are part-time or, you know, don't know what they're doing. They all, you know, came from doing something non-related to surgery. And these nurses have no idea. So like anything comes in, they're asking for all these workups and clearances. Just driving me crazy because they're constantly paging me. I have to go through every single patient.
We'll go back to Cornhole again, maybe he's softened up, I don't know. He
We'll
wouldn't-
bring that desk down.
Oh, God.
But there are no more full-time nurses in Lincoln.
No.
They're gone, it's
They're
all
so
part-time. So
incompetent.
nobody knows anything about anything, so just beware when you go there.
They're
The
clueless.
last full-time person left. So it's all 2 to 3 day weekers.
But I mean, also part of it is our fault, because every time the nurses come in and ask for, you know, check off the histories and EKG, we routinely just say, "Oh, okay, get medical clearance or cardiac clearance for any kind of questionable things without going through all the histories. So they have to jump through all these hoops. I mean, it's just, you know.
It's easier for them to order everything.
For low-risk procedures, we're asking for cardiac clearance routine on everyone.
It's not necessary.
None of
They
it.
don't need anything, it's like a haircut.
Wonderful. Thank you.
Thank
That's
you.
a very timely discussion.